Hello everybody, this is Dr. Medicine RX and in today's video we'll be discussing about Hailey-Hailey disease. Another disease that is usually discussed in conjunction with Hailey-Hailey is Darier's disease, and I have already made a video on it. Please check the channel for that video. So Hailey-Hailey disease is also called as familial benign chronic pemphigus. Familial because it is a hereditary disorder and it is autosomal dominantly inherited, and it is a benign disorder with chronic recurrences, exacerbations and remissions. It is a blistering disorder, that's why we have added the pemphigus to its name. So familial benign chronic pemphigus. It is an autosomal dominant, it is a rare disorder, and both males and females are affected equally. Coming to etiopathogenesis, there is mutation in ATP2C1 gene which is located on the chromosome 3, whereas in Darier's disease the gene affected is ATP2A2 gene located on chromosome 12, and it encodes for SERCA2b, which is required for pumping calcium from cytosol into the endoplasmic reticulum, whereas this ATP2C1 gene is located on chromosome 3 and it encodes for ATPase1, which is required for transporting this calcium into the Golgi complex, and it also utilizes energy, so it lyses ATP. It is also called as SPCA1, that is secretory pathway CA2 plus ATPase, and it is a magnesium dependent enzyme. So keratinocytes, they depend on SPCA for loading calcium into Golgi complex, and because of this loading there is an epidermal calcium ion gradient created, and this gradient, it is higher in the epidermis than in the lower epidermis, and this gradient is necessary for epidermal differentiation, profilagrin processing and lipid secretion. And because of mutation in that gene, there is loss of epidermal calcium gradient, especially in the upper epidermis, due to decreased epidermal Ca2+. As a result of this decreased SPCA1 activity, there is desmosomal instability followed by acantholysis. Coming to clinical features, it is a recurrent disorder and there is going to be recurrent eruption of vesicles and bullae, especially on the flexural sites such as axilla and groin. Other sites affected include nape and sides of neck, genital regions, perianal and periumbilical regions. Rarely scalp and extremities are also affected. So here the primary lesion is going to be a vesicle on normal skin. It rapidly enlarges and forms a flaccid bulla. This bulla, it ruptures easily and leads to an erosion which extrudes a serum. This serum, it hardens to form impetiginous crust. The lesions, they spread peripherally with a dry center and a circinate border, and painful fissures and malodorous vegetating plaques also occur, and Nikolsky sign may be positive, and mucosal lesions are rare, and nails, they are asymptomatic but often show longitudinal white bands. Coming to aggravating factors, this disease, it is more severe during summer because of the heat and UV exposure and mechanical friction and super added infections that are very rampant during the summer season. Coming to atypical variants, segmental type 1 and 2, papillar type, papillovesicular type, vesiculopustular type, verrucous type, lichenified and hyperkeratotic type of Hailey-Hailey disease are also seen. Coming to investigations, it is pretty simple because there are no autoantibodies formed here. It is simply because of a mutation in a gene that is required for creating calcium gradient leading to acantholysis. So on HPE, there is going to be intraepidermal cleft formation, and this cleft formation is at the level of spinous cell layer, and it also gives a dilapidated brick wall appearance to the epidermis, because even though the desmosomes are lost, there are some intact intercellular bridges between the cells, giving this layer of epidermis, the stratum malphigae, essentially a dilapidated brick wall appearance. The acantholytic cells, they are well defined, they have well defined nuclei and sharply outlined cytoplasm, and there are going to be few dyskeratotic cells in contrast to Darier's disease where there are many dyskeratotic cells, and these dyskeratotic cells may be present and occur as chorons of Darier's disease. So they may give the appearance of chorons which are seen in Darier's disease. And there is moderate lymphocytic infiltrating dermis. Since there is no autoantibody formation, the immunofluorescence studies are negative. Coming to course of the disease, there is going to be exacerbations and remissions present, recurrences are present, and the severity it decreases with age. Coming to management, systemic antibiotics, they reduce exacerbations, and the antibiotics that are usually selected include tetracyclines, penicillin, erythromycin, and minocycline. Corticosteroids, either systemic, topical, or intralesional, are effective. Dapsone 100 to 200 mg initially and followed by maintenance dose of 50 mg can be tried for refractory cases. And topical tacrolimus, talcalcital, calcitriol, systemic and topical cyclosporin, 8-retinate, methotrexate, and PUVA therapy have been variably effective. Persistent recalcitrant plaques can also occur in as the disease progresses and in severe cases. In that cases, wide excision along with grafting with the split thickness thin grafts is widely accepted mode of treatment. Other procedural therapies include dermabrasion, RIAG laser, CO2 laser ablation, and there are certain novel treatments such as low dose naltrexone and oral magnesium chloride that have been proven effective for recalcitrant and refractory cases respectively. Thank you. Subscribe for more.